introduction to the understanding of competency-based education. And in the inauguration, some of the speakers have given in the inaugural session, you have been given a lot of introduction about competency-based education. Therefore, I'll be skipping some of the contents to make up for the time. Education is a little shift away from what you are doing. Hello? Attention. Just imagine this competency-based education is a shift from your regular routine. Imagine you have been driving a car and you are accustomed to shifting the gear, working on the clutch and working on the brakes. Now you are given an automatic car, automatic transmission car. The rules are same, traffic rules are same, traffic is same, but the way you operate your vehicle, you have to adjust to the way you operate the vehicle. It's the same analogy that you can draw for the implementation of competency-based education. Your content is same, your subjects are same, your students are almost similar, but the way you deal with the student, the way you convey your subjects, the way you communicate is little different. And it starts with the foundational philosophy that the learner is focus of all educational activities. If we accept that learner is focus of our educational activities, there are two models of teaching that we have. The first model and the second model. Of these, which model would you be adapting if it has to be the learner-centric approach, first or second? So it's the second model that we are going to discuss here as competency-based education. By the end of this session, you should be able to state the theoretical background for CBDC, recall the milestones in the development of CBDC, outline the critical features of competency-based curriculum, and mention what is new in the curriculum as compared to the previous curriculum. These are the objectives that we have for this session. And as we look at these objectives, these four statements, you can see that there are two common features in each of the statement. One is each of the statement tells what you as participant will be able to do by the end of this session. It doesn't say what I will be doing. Whatever I do is secondary. What it expects is you will be able to perform this by the end of this session. And second is each of the statement is starting with a verb, and moreover it is starting with an active verb. As you look into the CBDC document under the column SLO, whatever statements that you see are listed like that. The performances that are listed there are what your students will do, not what you will do as a teacher. Second thing is each of this is listed with a verb in the column under SLO. We will revisit this by the end of the session and ask, are you able to do this? So the understanding is whatever objectives we state upfront will be the questions for the students. What you write here in the SLO will become the questions in the question paper. That is a relationship. Now, competency is defined as a habitual and judicious use of, you can see the word habitual, which means that it is something which is repetitive, continuous, and built into a person's nature. The competence is something which is built into a person. If a person is doing certain things today, not doing tomorrow, again maybe doing day after tomorrow, it doesn't become competency because there is no consistency. So competency is consistency, and the use of certain attributes such as communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection. All these are the attributes of a person who is competent. A person is not competent if he can only list that these are the causes of a particular condition, or these are the symptoms of this particular condition. Knowledge alone is not competency. Or the clinical examination alone is not competency. Or communication with the patient alone is not competency. It is a collection of all these attributes in the same person at the same time and consistently when he or she is dealing with the patients in the daily practice, either individually or with the communities. So it is a collection of all these attributes, whatever you see there, which constitute competency. When a person is doing the clinical examination, the person has the knowledge for it, the person has the ethics of the conducting that, the person is also showing the communication and is reflecting on how I can improve further by learning from this. So when you get all these attributes together into a single performance, that performance is said to be a competent performance. Now what is competency-based education? Competency-based education is defined by the American Association of Nursing Colleges, Colleges of Nursing, and the same definition we can also adapt. What they say is, it's a system, competency-based education is a system of instruction, assessment, feedback, self-reflection, and reporting. So you can see a range of activities that happen in an academic situation, and these range of academic practices are based on the students to demonstrate that they have learned the knowledge, attitude, motivation, self-perception, and skill. Now whatever you see here are the same attributes we had seen in the competency. The same list of competencies, attributes, the students have to demonstrate. In a competency-based education, the students have to demonstrate the range of attributes which are considered as competence as they progress through their education. It is not just the completion of education. It's not that by the final year they should be able to do that. It is as they are progressing continuously, they are acquiring those competencies on a regular basis. And finally they have the final competency. So it's not that the competency comes all at once in the final exam. It is a progressive thing. And for the progressive thing, there is a continuous teaching, continuous assessment, continuous feedback, and continuous improvement. This is what is the hallmark of competency-based education. And to do this, you have to give certain liberty to the student, certain freedom to the student. And you have to give up certain factors that hold you back from giving that liberty to the students. How does a student become competent is when they are given the opportunity and freedom to progress at their own pace. Not every student will learn in the same pace. Each person has a unique way of learning, unique pace of learning. So you have to give that freedom and opportunity for the students to progress, and their learning experiences are structured according to their needs and their interests. So the student, it is a student who is learning, so their individuality also has to be accounted for as they are learning. More of this we'll see a little later, and these are the expressions which are seen as part of multiple studies which have been completed, and these are some of the examples of the studies which we have there. Then how did this competency base, okay, now before that, if this is competency, and you expect a competency to have a kind of A to B trajectory, like you start here and directly the person becomes competent. It doesn't happen like that. There are various ways a person learns. There are many ups and downs. And there are some ways a person may go back and learn, may repeat certain things. And there could be many such examples for each person. Each person can have a graph like this, which is individual to that person. So with this in the background, the competency is based on certain principles, certain theories which have formed the foundation of developing these competency-based courses. So therefore, these are the things, we are not getting into the details of this, you can search for all this. And as the competency started, the initial stepping stone for competency was a divergence from a traditional curriculum. The traditional curriculum was implemented in the early 20th century on the model that was said to be a Flexnerian model, designed by one person called Abraham Flexner in the 1910, the report was published. And that report, interestingly, was the one which brought down the education and practice of homeopathy in the US and later into the other countries. So as a result of this, a new medical education policy was introduced, which was adopted all over. But very soon people thought that they started realizing that this is not the model that is appropriate for them or proper for them. So they wanted to have a different model. The first attempt was made by Case Western Reserve University in the US, and they had a different model where they started teaching the integrated system-wise training. Like in the first semester, they may teach about, say, the respiratory system, the entirety of it, the anatomy, physiology, biochemistry, pathology, patient management, the entire thing. In the next semester, another system in the next semester. Like this, they would complete those systems, and this was a kind of divergence from the established medical education policy. And from there, the WHO brought out a paper called Competency-Based Medical Education in 1978. And building on that, there were two individuals who are notable to mention here. One is George Miller, was a physician, and he brought out whatever you see as Miller in one of the columns that you see Miller. This is a Miller, George Miller. He designed that the clinical performance of any student or any practitioner can be measured successively, progressively, from what the student knows to what the student knows how or understands how it works and demonstrate how it works and independently performs. 4 levels: knows how, shows how, and does. So this is what George Miller said, and it became a kind of revolutionizing tool in the student assessment and also of student teaching. The second notable contribution was by Ronald Harden. Ronald Harden is known for certain things that you all have been hearing now of late because of the CBDC and QCI, something called as OSCE, Objective Structured Clinical Examination. It was Ronald Harden who introduced it in early 70s, and it was published after a lot of experimentation and studies in 1975. And since then, it has been one of the revolutionizing way the student is being assessed clinically. The second thing that Ronald Harden contributed was a model of curriculum called Spice's model of curriculum. What he said is the curriculum should not be teacher-centric. It has to be student-centric or learner-centric. It should be problem-oriented. It should have community orientation. There should be integration. There should be electives, and it should be system-based. So all these constitute what he called Spice's model, and it is a Spice's model which has formed the foundation of competency-based education that you are seeing now. So these are the contributions from individuals, and as things were moving on further, the national associations or bodies from US and Canada in the 21st century, they stepped in and designed a very robust framework of competencies, where the CanMeds and ACGME said these are the framework. Like we have syllabus, they have the frameworks, and universities are free to design their syllabus. Here universities have to follow whatever syllabus is given by the apex bodies, but their model is something different. So designed a framework, and according to that framework, the competencies were listed, and these competencies were to be the cornerstone of any medical education. And this became the competency-based medical education. And finally, in the early 21st century, we have a new wave called entrustable professional activities. Now, entrustable is you can independently trust the person to provide whatever is the health care. Now, competent is a different issue. This person is competent, you certify. But do you certify this person, whomever you have certified, do you have confidence and complete trust that he or she will do in independent practice in the different contexts? And that is what is the next level which has come as entrustable professional activities. And the postgraduate syllabus of homeopathy is designed according to the EPA, or Interestable Professional Activities. And NCH is the first national body in India for any professional body which has adopted EPS. Not even NMC has adopted it. Dental has not adopted it. Pharmacy has not adopted. No other national body except homeopathy. So this is a first for the homeopathy also. Now coming to what is the philosophy, what are the changes that you see? One is that the competency-based education is learner-centric. And because it is learner-centric, and you expect each person to be able to perform, because when you say learner-centric, it is like individualization. And this individualization is for each student, just as you individualize each patient, because each person is unique. That is what you believe. Each student is unique, therefore it has to be individualized. And as a result of this individualization and as a result of this individual focus, what happens is the students develop their identity. The identity as a homeopathic practitioner. Now, there are some kind of complaints, there are some grouses that some of the students who pass their homeopathy or who get their homeopathic qualification do not practice homeopathy. What is the reason? There could be many reasons. But the major reason is that they have not developed their identity as a homeopathic practitioner. If they develop their identity, if I have an identity, I have value for that identity. My identity, it is me. And I have value for it. If I don't develop that identity, I have no value for it. And that is the reason why there is a kind of digression which happens. And why that identity doesn't develop, there could be many reasons. There could be lack of confidence, there could be lack of whatever opportunities, there could be many things. We are not justifying that. But the way the competency-based education is designed and the way it is to be implemented, if everything goes as per the schedule and as per the expectation, then this is what will happen, that they will develop their identity. So the other things that happen in this is, it is competency driven because of the competencies which are expected to be learned by everybody. Everybody becomes a master of that performance. Then you have a programmatic assessment, more of this we'll see later. It is a new approach to student assessment. It is called programmatic assessment, and this is something which is very, very unique to competency-based medical education. As a result of this, the person has a continuous feedback for improvement. Feedback and improvement. And finally, you have the intrinsic motivation, because intrinsic motivation is that when we want to achieve something, like you are getting the identity formation, that is the intrinsic motivation. Extrinsic is to pass the examination, to clear the course. And after clearing the course, what happens? That's a different issue, because if there is no intrinsic motivation, I don't have the kind of passion, I don't have the drive, and I don't have the identity. So because of the intrinsic motivation, there is a continuous way of learning, lifelong learning. The two major issues you can see as the differentiators in competency-based education is, one is the competency, the other is the time. In the competency-based education, competency is fixed. It is constant. There is no compromise on the competency. Everybody who gets their BHMS degree in competency-based education must have those competencies. They are to be certified in those competencies. That is the ideal thing. So when the student passes the BHMS competency-based CBDC, it is proven, it is accepted that they have these competencies. But the time that each person may take differs. Whereas in the previous version, the time is fixed. Within 4.5 years, the student has to complete the course. What competencies they will gain is something which is flexible. Some may gain the competency, some may not gain the competency. We can take credit to say that 80% of our students are passing. So that means 20% are failing. So those 20% have not gained the competency. That is a shift which now happens. No, you may ask, we have only 4.5 years. If the time has to stretch, does it mean that we have to make it like 7 years, 6 years course? Right, so this could be one doubt. What happens here is, within the time frame of those 4.5 years, the way we can make a flexibility of the timing for the student and teacher. That is where the flexibility of timing comes. But the competency is fixed. More of this we'll see later in the next sessions and also during the afternoon sessions when you have the individual subject topics, how this time can be adapted for within the time frame, how you can adapt using different tactics. And what is new is you have foundation course, then you have early clinical exposure, then the electives are there and alignment and integration. These are the visible changes which are there in the competency-based curriculum. These were the objectives that we had. You can self-reflect and answer to yourself how much you are able to do that. With that, we move to the second part of the session. This is about the modus operandi for implementing the CBDC program. By the end of this session, you should be able to outline the structure of CBDC document, recall the key phrases in the CBDC document, discuss the institutional capacity building for implementing CBDC, describe the functions of CBDC committees, and illustrate the organizational structure for the implementation of CBDC. As you can see here, each of these 5 statements tells what you will be able to do. And if you look at the structure, each of them starts with a verb. The reason why I am insisting on these 2 points, and that you will be doing it and there is a verb in this, is that we need to kind of internalize this. It has to become habitual for the teacher to write these SLOs, to adapt these SLOs, and to check that it has an active verb. Only then the teacher competency will build in. One of the dimensions of teacher competency is that it has to be habitual. The specific learning objective has to be kind of stated upfront. Whether I am taking a lecture, whether I am making a demonstration, whether I am doing a clinical presentation, whatever I am doing as a teacher, I need to share with the students, if not before, at the beginning of the term, at least in the beginning of the lesson, that these are the expected outcomes after this session. The previous model of curriculum was where we had the list of topics. These are the topics which are there. And these topics we teach. After teaching, we conduct the assessment. A linear model was there. This is how the things were happening. And this is called as the transmission model. Transmission model is where we have a transmission tower. It could be the telephone transmission, electricity transmission, whatever tower is there, and that transmits the telephone signals or electricity, and there is a receiving end, like you have your mobile phones. These are receiving. If there is no receiving, you are not getting signal. Here you are sitting here, you are not getting signal. What could be the problem? The tower is telling, no, my signals are very strong. I am sending, but you are not receiving. It's not my problem. It's your problem. So who takes the responsibility for this problem solution? There has to be somebody who takes responsibility. And in the context of academics, it is a teacher who takes the responsibility. No, I cannot say that, see, I have taught. He has not learned. Not my problem. So that cannot happen here. Therefore, the new model is where we have a different approach from the phase of designing. As you design the curriculum, as this curriculum has been designed, it is based on what are the national goals. What does the country require for the healthcare of its population over the next 30, 40, 50 years. So whomever you are training as a practitioner, a homeopathic practitioner, will be in circulation for probably the next 20, 30, 40, 50, whatever number of years. So with this intent, what is that the country requires of them, the national goals are written. And depending on the national goals, what is the strength of homeopathy in that, that has defined the program objectives. As you look into the BHMS curriculum, you see the program objectives, which are for the whole of BHMS, not for medicine, not for surgery, not for pathology. It is for the entire BHMS course. These are called as program objectives. And where do the program objectives come from? From the national goals. From the national goals, you have the program objectives. Now you can see a kind of logic emerging on why this curriculum has been designed the way it is designed now. And from there, these are the objectives, and this is the graduate outcomes. A person who comes out with BHMS will demonstrate these attributes. A list is there. And these lists, what are the contents that they require? What are the competencies that they require to learn? These are listed first. Before they are implemented, we check whether this is implementable. Is this necessary for a BHMS graduate? Is this possible for a maturity level of a BHMS graduate to perform? So that kind of internal thought process happens, and there is a feasibility study of whether this can go into the syllabus, or we have to modify, or we have to remove, or it passes into that. So once that feasibility study says, yes, this is something which is possible for a BHMS level person to perform, then it gets into the syllabus. After that, the teaching and the assessment that will happen. So here what happens is, as the teaching is happening, you are again assessing whether the student is learning and giving feedback to improve their learning so that they acquire those competencies. And this model is called transformation model. You are transforming a person to demonstrate those competencies. And as you are transforming, you have taken the responsibility to transform the person. You are checking if the signals are reaching there or not. If the signals are not reaching, what is the reason? Whether it is the handset which has a problem, whether it is the medium which has a problem, or whether it has a transmitter which has a problem, or whether it is the content which has a problem. What is the problem? So that you check what the problem is with the student, with the teacher, with the institution, with the environment, or whatever the problem is, you solve those problems and see that the students learn. This is a transformation model. And this is where you take the responsibility of changing the students into competent people. And how did this whole process start? The first thing was the competencies were written. If you look into the second column of the CBDC, you can see certain letters, KS, HO, PC, PRF. Now, these are what are called as domains of competencies. The basis of this was the documents or the frameworks that I referred earlier from ACGME and CanMETS. And of course, there are some other documents from Scottish Doctor, then the GMC requirements. All these things were taken, and finally, how it is appropriate for a homeopathic course. This was defined, and we defined 6 domains of competencies: knowledge and scholarship, patient care, homeopathic orientation, professionalism, communication, practice-based learning. So these are the 6 competency domains of competencies which are listed, and whatever learning happens will be relevant to these domains of competencies. It could be into one domain or it could be into multiple domains. So this is what is a competency. As you see the competency in the second column, what you see is this competency. And this competency, once it was listed, what are the levels of this competency performance? This was made on the Miller's level. The same Miller that we saw earlier, which had knows how, shows how, does. So you have a competency which is listed, performance competency. This domain competency, now you come to performance competency. The student will be able to perform this at what level? Is it at the level of the student knowing certain thing? Is it at the level of student understanding certain things? Is it at the level of student performing certain things under the supervision? Or is it at the level of student doing certain things independently? So these were defined, the levels were defined. After the defining of the levels, what is the required content for it? What is the subject matter that would be required for the student to learn this, subject-wise or interdisciplinary-wise? And this content was further classified, whether it is cognitive, affective, psychomotor, into Bloom's domains. And then, within the Bloom's domain of cognitive, psychomotor, affective, what is its level? Is it entry level, intermediate level, or higher level? So when you look into the levels, you will see something like C1, C2, C3, or A1, A2, A3, or P1, P2, P3. This C means cognitive knowledge. A means affective, which is the communication or values. P means psychomotor, which is the skill. Now, when you say C1, it is the entry level of cognitive domain. The student is able to know K. If you see it as C2, it is the intermediate level of cognitive where the student knows how. If you see it as C3, it is problem solving or decision making. If you see as P1, entry level of the performance, the skill performance, the student is observing. If it is P2, the student is performing under control of the supervisor. If it is P3, the student is performing it independently. Similarly, A1, A2, A3, which is observing, responding, and internalizing. So these are the levels that you see according to Bloom and Gilbert. Once Bloom and Gilbert is there, you have the SLO which is listed according to this. With all this exercise, you state this is the SLO or the outcome, specific learning outcome. And to implement this specific learning outcome, you need to have the priority. Not all the SLOs are having the same priority. So something is called as must know, something is desirable to, something nice to know. And as you see there, under that column, you see MK, DK, NK. Must know, desirable to know, nice to know. And these have been defined with some kind of a background logic of what is the impact and what is the frequency of that learning, requirement of that learning. So taking the formula of the impact and frequency, the priority is defined. And once you have the priority, what are the methods of teaching and what is the method of assessment? This is what is there. And finally, you have the integration in the last column. This is behind the screen activity of what happened in the designing of curriculum. So if you have any doubts about why this has come here, how it has come here, you can ask your subject experts in the afternoon. They will be in a position to explain to you what is the logic that this is there in the syllabus. And now coming to what you see on the screen, you have these 10 columns, and each of the column represents a particular element. The first column is the list of the number, serial number. And the serial number is not a simple serial number. There is some kind of coding which is done. As you see there, you will see that it is UG, MM01, something like that. So it means it is undergraduate, materia medica, the first competency, then further competencies. So that there is a kind of codification of competencies throughout. The second is the competency, whether it is KS, PC, HO, whatever it is, whether it is knowledge and skill, whether it is patient care, whether it is homeopathic orientation, then whether it is problem-based learning, all those things are there. The third one is the Miller's domain. There you will see K, KH, SH, D. So whatever that means. Then you have the content, what is the subject matter is given in the next column. And this subject matter is further written as SLO. What is a specific learning objective? Those statements are written. And the description of the statement at the domain and Gilbert level, Bloom and Gilbert level, A1, A2, A3, whatever that is given there. Then the seventh column is the priority, which is the must know, desirable to know, nice to know. And then comes what are the teaching learning methods and media. And of course the assessment, which is formative and summative. And finally you have the integration. This is what is the snapshot of the document. The entire syllabus has been reorganized into these slots. Now what has happened is there is a clarity of each purpose. What is this SLO? What is this, whatever things, the different components are there, these have been clearly defined. And as you look through this, you can see that there are some words which are very specific. There is something called Bloom, there is something called Gilbert, there is something called Miller, there is something called as competency, there is something, different names are there, formative is there, summative is there. All these are new terminologies. And the description of these terminologies is given in the introduction part of the syllabus. You please go through that introduction part, and only after that you start reading the syllabus, so that you get to know what are those, the phrases. And then, for implementing, this is where the implementation part comes. For implementation, the first requirement is that we should be compliant with the new minimum essential standards. Only if we have all these things, the rest of the things can fall in place. And then, what is that? requirement. The requirement of training or capacity building is at two levels. One is for the academic governance, and second is what is called as the educational methodology. I'll take educational methodology first. It requires a training in basic course of education methodology. There are many options. There is a 2-day course, there is 1-day course, there are year-long course also. Whichever is feasible for you, you can get into that. And the teachers have to be trained in that. I'll come to what are the contents in that. The second is to have micro-teaching sessions to improve the performance of teachers in various levels. And third is to have multiple workshops on designing lesson plans and designing the question paper and designing the theory paper and designing the practical assessment protocols, the clinical assessment protocols. So these are the activities which need to be done for teacher capacity building. And this teacher capacity building happens at 3 domains from 3 elements. One is called as how do the teacher understand what is the purpose of his or her teaching? How do you rate the specific learning objectives? Or how do you identify the specific learning objectives? So that is one component. The second component is the instructional activities. What is the teaching learning methods? The third is the assessment methods. And these are interconnected, and this is called as the spiral of curriculum, because the learning happens from the next level to the next level. After assessment, you say the next level of assessment starts. So it's like a spiral of curriculum. So these are the 3 components which have to be included into any training of education methodology. And the specifics of each of this is under the educational objectives. The teachers have to know what is Bloom's taxonomy, what are the Gilbert's levels, what is Miller's pyramid, then what are the components, what are the attributes of a specific learning objective, what are the elements of a specific learning objective, then what are the levels of the objectives outcomes as to program outcome, course outcome, specific learning outcome, and what is the prioritization as must know, desirable to know, nice to know. This is a basic requirement for any teacher to know for the implementation of CBDC. In the understanding of the SLOs. So whatever SLO you see in the document, you can only make sense out of it if you are aware of these fine aspects. Then for implementation of the teaching, there are certain teaching methods that you have to understand. One is what are the students? Your students are adults. How do the adults learn? Because that is your audience. You have to know your audience for implementing something. So how do the adults learn? Then what are the ways that you select, this is the appropriate method. Say I want to select lecture. On what basis I say that lecture is best for it? Or I want to conduct a group discussion. What is the reason for me to say this is the best method for this condition or this situation? So there are some reasons. And then there is a list of the teaching tools. What are these teaching tools? Then what are the teaching learning media? What are the audiovisual methods? How do you map these to the teaching methods? And finally, what is the outline or the basic lesson plan? So these will be included into the teaching learning methods and media. And as you conduct assessment, you have to understand that assessment is based on something called as constructive alignment. That is, the outcomes, teaching and assessment, these have to be fused together as a single entity. That is when the assessment becomes more effective. And then there is formative or summative assessment, or direct or indirect assessment. Then you have something called as the tools of assessment, which are specific for each situation. And then the whole assessment is called the program of assessment. More of this we'll see in the last session. Now, for implementing the actual academic governance, you need to have something called as Curriculum Coordination Committee. What it is, we'll see later. And it should be meeting at least once in a month initially to make the planning and other things. And this will be reporting to the College Council at least once in 6 months. The purpose of Curriculum Coordination Committee is for planning, organizing, coordinating, monitoring, and evaluating of the syllabus. Because you have to know how the progress is happening. If we simply have one meeting at the beginning of the year and forget about it, if you are not tracking, you may not reach with the same pace. So you need to keep track of what is happening. That is what the Curriculum Coordination Committee does. It is coordinating for the implementation of curriculum. Therefore, it is not a single committee. It's a overarching committee. There are other committees below that. So what is this composition? This composition is that the CCC has the head of institution, which is reporting with the college council, and under the curriculum coordination committee, you have to differentiate it from the other two entities called Institutional Quality Assessment Cell. If you are into NAC, this is a separate committee called IQAC. The curriculum coordination committee is different from IQAC, it's not the same. Then you have something called as METU, which has now become compulsory for all colleges to establish according to the new minimum essential standards. It's about medical education technology unit. The CCC is not medical technology unit. It is something different. So these are different. And you need to have an understanding that the subcommittees include foundation committee, electives committee, assessment, early clinical exposure, alignment and integration, and of course, multiple departmental committees. So each of the committees has a specific composition, and each of these committees has a specific function. The list of this whole thing is written into a handout of about 6 pages. I've shared it with Dr. Jatkar, and he will be sharing it with all the principals. By the end of these sessions, you can get a copy from him through a principal and try to understand what these are. And the second thing that you also have to understand is, as a leadership, there is something called as learning organization. I'll not get into the details of it. This book is called the fifth discipline, written by Peter Senge, and this is something which is very, very kind of having a lot of commonality with homeopathic understanding. There's something called as systems thinking, which is very, very similar to what a homeopathic philosophy is. And this is a very highly recommended understanding for anybody who wants to be a leader. About leader, let me tell only 2 words, 2 sentences. Everybody is a leader. You are a leader because you can do anything. If I say, I can do anything, I'm a leader. But the second thing is important. I cannot do it alone. Is the second axiom. So if you understand these 2, you are a leader, and that is what is the gist of this book, Fifth Discipline. With this, in the afternoon session, these are the objectives that you will be checking out. I will not get into the details of this. Sorry, these are the 9 objectives you will be checking out in the afternoon session. The subject expert will be explaining more of this. With this, we will come to the conclusion of this. And I'm told there is a kind of tea break of 10 minutes. We'll come back by, now it is 12:25. 12:40 we are back here.
Let me explain you the afternoon session. This session will be around 60 minutes. Then there will be the lunch break. After lunch break, you will go to your respective classes for your specialty subject.
Syllabus and the new syllabus. And the session is on the teaching learning methods for CBDC. We may come to this situation sometime. So by the end of this session, you should be able to mention the adult learning principles, explain the context of learning for CBDC, classify the teaching learning methods, discuss the relevant teaching learning methods, categorize the teaching learning media, and validate the need for a lesson plan. These are the objectives. As you can see, each of these says what you will do, and each of these has an active verb at the beginning of the statement. In the context of communication, that is face-to-face communication, when you are discussing, when you are interacting with the students, with whomever, 55% of the influence is from the body language. The way we are, the way we create the environment, all these constitute about 55% success for the communication. And the 38% is for the way we speak, the voice tone, the pause, whatever, the way we speak, It's about 38%. And the remaining 7% is the subject matter. Our subject knowledge has 7% influence for the success of learning. So if you want to make 100%, you have to adopt these. So this is something which we all need to understand in the practice of teaching. And our learners, we classify, there are many theories of learning. More than 100 theories are there. In that, I have picked one which is very, very relevant. It is called as VARK model, V-A-R-K. Visual, auditory, read, write, and kinesthetic. So what it says is, there are some learners who are purely, or who learn better when they see something. These are called visual learners. And there are some learners who can learn better when they hear something. They learn better only when they hear. So they are the auditory learners. And there are some learners whom you would have seen, they keep on writing the notes, scribbling everything that they hear in the classroom or wherever. These are called read-write learners. 90% of the entire learning population is into either the audio-visual and read and write. These three categories make up 90%. So the mainstream teaching efforts in the classroom, in the demonstration, all these are sufficient for the 90%. But there is still another 7% of the learners who are said to be kinesthetic, that they learn only when they do. They don't learn in the classroom lecture, they don't learn when they see something, when they hear something, only when they do. The reason why you have to understand this is, when you are in the process of empowering the students to achieve mastery, it requires that every student achieves mastery, even those 7% of the students who are not the mainstream learners. Therefore, to identify who are the learners who are not into the mainstream and support them additionally with whatever is their style of learning, whatever is their way of learning, you need to understand who these students are and what is their strength of learning. Don't call it weakness. It is their strength of learning. So what is their strength of learning, we need to understand. For that, there are many learning theories, multiple learning theories, you can read up them. But one basic theory is called as the VARK theory. The second thing that you have to understand is about the actual nature of the adult learners. All these adult learners have certain main features. In fact, you can reflect that you all are adult learners. Since morning you have been hearing certain things. Are you accepting everything that you have heard? Or you have some doubts about whatever you have heard? The reason why you have some doubt about what you have heard, you are not convinced about it, because you feel that it is not necessary for me. I might have talked something which you feel is not appropriate, not relevant. So the students will learn when they need to know. As a teacher, you have to create that awareness of what is the importance of this, what is their need, that they have to learn this. When the students are learning some different things in, say, biochemistry or anatomy, they don't see the reason why I am learning this anatomy or physiology or this biochemistry. Only when they are given the understanding that how this is relevant for their professional competence, then they will realize, okay, this is important, that I need to know. And this comes in the integration which is there in the various preclinical subjects. So that is the importance, one of the importance of integration. Students will learn when they need to know. Then the students have a self-concept. As we already have seen, visual learners, auditory learners, they know the way they learn. Because it's like my individuality, I know what I am. Therefore, the learning of the individuals is something which is individualized. They have a self-concept. And you have to be aware that this is their concept of learning, that is their concept of learning. And don't impose one method of learning for everybody. What they are comfortable with, the freedom and the opportunity to learn at their own progress. What we said earlier for competency-based, that is what is the importance of this. Then experience. As you are listening certain things, you are reflecting. Is this the way things work out in my class? Is it the way that things work out in my, whatever, the way when I am teaching? You are like relating it to your experience. Similarly, your students also relate whatever we are teaching to their experience. If you are teaching surgery, if you are teaching medicine, they are trying to relate it with whatever they have learned earlier in their pathology, in their anatomy, in their physiology. So the experience counts as a foundation for any learning. And readiness to learn. If the students are ready to learn, they will learn. If they are not ready, they will not learn. And when do the students become ready to learn? When the exams are announced. When the exams are announced, they suddenly become ready to learn. Therefore, in the CBDC, there is a model of continuous assessment. This model of continuous assessments keep the student ready to learn continuously. Then the orientation to learn is about an issue, about a problem. You all want to learn how to solve a problem. Like students are not attentive in the class. What should I do? The students are not showing interest in completing the assignments. What should I do? The students are not keeping track of their time. What should I do? These are the problems. If I keep telling only the theories, what is the use of theory when it cannot solve my problem? Therefore, the students have to be learning how to solve the problem. Now, the solving the problem is when the patient comes with a disease. Patient does not come with anatomy or biochemistry. So the understanding of anatomy or biochemistry is important to the extent that it can solve whatever problem the patient has come with. So this is what is the orientation to learn. The orientation to learn is about the professional performance. And these are listed as course objectives. If you relate the training and teaching to the course objectives, which are more broad, and then come down to the specific learning objectives, they can see the connect between what they are learning and why they are learning. And finally, it's about the motivation to learn, which is intrinsic. Intrinsic motivation comes when they are made aware that why they are learning for their professional identity formation. So this is about the way adults learn, and the way you select the teaching method depends on multiple factors. One is what is the student type, whether the student is auditory, visual, kinesthetic learner. Then you have the context of learning. The context of learning could be in the classroom, it could be in the clinics, it could be in the laboratory, it could be in the community. Then what are the domains of learning? Could be cognitive, affective, psychomotor. Then you have the size of class, large, small, and individual. When you say large class, it is about around 50 or more. When you say small group, it is about 15 to 20. If it is individual, it is 1 or 2. So depending on what is the number of students that you have, some of the teaching methods are more appropriate. And who is the control of learning? Is it the teacher control or learner control? This is called as the balance of power in sociology. Who has the balance of power? Like who has to dictate? Like for example, in lecture, it is the teacher who is in the control. Imagine students gain control in the lecture class. What would happen? So similarly, something like an individual study, it is the student who has to be in control. If the teacher is interfering into that, imagine what will happen. So this is about the reasons for selecting are the factors which help you to select what is the appropriate teaching learning method, and it is logical. And then these are the contexts which we discussed earlier. Now when we talk of the different teaching learning methods, these are classified as cognitive, psychomotor, and affective. So some of these are for cognitive, these are for psychomotor, these are for affective. In fact, most of these you are aware, I don't have to kind of get into the details of it. Some of these are also explained in the introduction part, and there is a handbook which the National Commission is coming out with detailing all this. Maybe in a few weeks' time it will be available to you. So whatever doubts you have, you can get them clarified. And these cannot be discussed threadbare in a kind of sensitization session like this. So there are the teaching methods which have been classified specifically for cognitive domain, specifically for psychomotor and affective domain. And similarly, we have the teaching learning methods for the basis of size, for the large size, for the small size, and in between the large and small. Then you have individual and something which is in between the individual and small group. So these are some of the examples of teaching learning methods. And these methods, some of the examples you will identify in the post-lunch session, where the teachers will explain to you what is the TL method for this, what is the medium for this, and what is the assessment method for this. Those columns, specific columns, they will be explaining to you. And then this is what is called as the attention span. Our attention span is said to be about 20 minutes. That was what we had thought of earlier. Now there is a kind of revision of this timing. It has come down to about 3 minutes now. It's about 3 minutes. And taking this 3 minutes as the attention span, the educational planners have come out with the solutions which is now called as micro-learning. Micro-learning is where we have modules of only 3 minutes. If you look into any of the online courses like in Coursera, the videos, for each of the session there are 5, 6, 7, whatever number of videos, but each of them is not more than 3 to 4 minutes. So that is what is called the micro-learning. So micro-learning is based on this so that the student's interest is kept intact. And the other way that you can keep the student's interest intact is by using some medium of presentation. Along with the teaching method, whatever medium that you can also adapt. These are based on the theory called the cone of experience. How does a student or any learner retain the information? What this person, Edgar Dale, said is, we retain 10% of what we read, 20% of what we hear, 30% of what we see, and 50% of what we see and hear, 70% of what we do, and 90% of what we teach. This is a cone of experience, and whatever you see beyond 30%, 20, 30 or whatever, these are called as passive learning. And whatever you see here, these are called as active learning. Active learning is where the students are involved into learning. What is happening now is passive learning. You are not involved into your learning, you are only receiving. It is a transmission model now. So what is required is to have a follow-up. After this, there has to be a follow-up at the individual institution level, at the individual university level, where the subject people of each of the subject of not more than 25 to 30 teachers get together, and they are trained intensively for at least 2 days in their subject matter of the education methodology. So into what is this objective, what is this teaching learning method, what is the assessment method, and you design the question paper, you design the checklist, you design the teaching method, you design the lesson plan. All these activities when you do individually, that becomes what is the active method. And that is what happens in what you say here, workshop. When we say workshop, what comes to our mind is an automobile workshop. When your scooter or car is not working, there's some problem, you take it to workshop. They repair and send. So similarly, we go as teachers to the workshop, they repair and send us. Like it is like not repairing, it is like honing the skills. There are skills of say teaching, there are skills of discussion, asking questions, viva questions, then preparing the checklist, preparing the question paper. All these are the skills which are taken care in a workshop. And that is what I was referring to you earlier. When you have about 20-25 teachers in a group and you get intensive 2 or 3 day session of preparing, discussing, and finally adapting. That is what has to happen for the success of this. Then the media, you can have the projected medium or non-projected medium. Projected is where some projector is there. Non-projected doesn't need any projection. And the models of this could be something like these are all projected media. Most of these you are aware. And this can have a background effect, or you can mute and use your own voice over for whatever is the medium that you are using. Some visual medium, some video is there, some animation is there, and that has their own voice. You can mute the voice, use that animation, make your description for that. So that also can be done. And the non-projected media, you have all these models, specimen models, and then charts, books, some reports, whatever is there is non-projected media. And these media, if you have to mix and match with the teaching methods, for all the large group teaching methods, whatever is the projected medium is more appropriate for a large group. For a small group, what is required for individual, it is those non-projected. For example, if you have individuals, somebody is learning, you have a lab report, each person has a lab report, they are reading that. And for the small group, a mix of these. Let us take the lab report. Each of the student has to identify what is the normal value in that and what has changed in that and interpret what is the change. Each student has a lab report, that is the non-projected. And the same thing can be projected onto the screen and the teacher can interact with the students. The whole thing is here, lab report is projected and they have the same copy there. So it becomes a kind of interactive. So that way also there can be, you can use your wisdom of how to use it for that context. Can you see that? That line? Readable? Clear? Not clear, okay. No clear? Why did that become clear? Please see those lines. There is a convergence. Just imagine you as a doctor. And now I'm imagining you are a doctor. This is your knowledge of the patient or your observation of the patient. And this is your knowledge of the disease. Your materia medica, your diagnostics, repertory, all these things. When these are not coming together, the prescription, when they are coming together, the prescription, right? Now you got a grounding of what is the convergence from your very basic professional understanding as a doctor. Now come back as a teacher. The teacher is a student. When the teacher and students are not on the same page, when they know what each other is doing, this is what happens in a lesson plan. Lesson plan is a document where you have the teaching activity which is spelled out by the teacher and that the students are aware this is what the teacher is doing. Right. So lesson plan is not a very rocket science. You only have to have a kind of document where you list these are the objectives for this class or these are the outcomes I expect the students to perform in this class, and for this is the content that I am preparing, and these are the teaching methods, and this is how I will assess the students during the class, by the end of the class. That's all. You don't have to write what is Gilbert, what is Miller, what is, all these things are not necessary. You only say these are the objectives and these objectives are there in whatever the column of your CBDC. You draw that under that competency. You write those list of 3, 4, 5, 6. Then what is the method? That also is written in the table. If you want to modify it, you modify. And assessment formative, whatever is there, that formative is there. Over. And once you do that, next year you can use the same thing. You can recycle it. Right. So this is what is lesson plan. And for the lesson plan, what is required is to understand that there is a constructive alignment. The outcomes, the teaching methods, and the assessment, all these have to come together into one document. And when these come together into one document, that is called the planning document, and with the micro unit of each presentation, that is called as lesson plan. So by the end of this session, if you are able to do all these things, and finally what I would say that vindicate the need for lesson plan, you have to kind of justify why we need a lesson plan. So with this, we go further into the last session. Look at the painting. What is the painting? What that person sees. It is not what it is. It is not what it is. And sometimes this is what happens in the exam. Exam is what we see, not what it is. But in competency based, it cannot be like that. It has to be what it is. So therefore, how do we see what it is the whole game in the competency based assessment. So by the end of this session, you should be able to state the purpose of assessment, illustrate the concept of programmatic assessment, this is something new, classify the assessment methods, explain the theory-based assessment tools such as multiple choice question, SAQ, LAQ, SEQ and MEQ, what these are we'll see. Then describe the practical or clinical assessment tools. So whatever we have there, we'll discuss what those are. And finally, discuss the role of structured oral examination. These are the objectives. And as you can see, this is what you will be able to do. And each of the statement has an active verb. This is the kind of habit formation that we all need to build up. The purpose of examination, as we all know, one of the things we all agree is pass or fail. This is on purpose. Depending on the purpose, the nature of test will differ. If you have to say the student has passed or failed, you will use particular method of assessment. And if you want to say the student has some knowledge, already existing knowledge, experience, we said, all adults come with experience, to check whether the student has that. If that is a purpose, there's a different method of assessment. And when we do the pre-test, after that we start teaching. As we are teaching, we have to check whether the student is learning or not. That is what is called as the monitoring of learning, which gives feedback to both the student and teacher. That is one purpose of assessment. One purpose, as you are observing, you can see the students are interested, not interested, they are focused, not focused, all these things are there. This also is an assessment. It is not that when the students write the question paper, answer paper, it is assessment. When you observe the students, their interest, their attention, attentiveness, even that is an assessment. So feedback to the student and teacher, which can diagnose what is the learning problem. If there is any problem of learning, students are not learning, what could be the reason and how it can be solved, what is the modification. And then it is also important to redefine. Now you all completed the first year CBDC. How effective it was? Shall we continue the same way it was or we need some modification? Now we are discussing about second year CBDC. After completing 1 year, we'll get to know whether it was right way of implementing or was there something which needed some modification. And this you cannot say as an opinion. We conduct something called as evaluation, program evaluation. And that is what is the purpose of conducting the assessment. And finally, it's a kind of safety to society. We say this is a person is having all these competencies. We certify independently this person can do these things. Now suddenly a case comes and what happens you can imagine. You can imagine good and bad both. Good, fine. If bad something happens, then who has done that? Right. So you need to have that also in mind. I'm not saying that you don't pass all the students. Pass all the students. But ensure that all of them have the competency of being safe to the society. They are safe to society. That's also one of the purpose of assessment. We'll have 4 images. Just look at each of these images and see what is happening. Okay, now there is a clarity, right? Now, as you look into this image, in the digital images, pictures, these are called pixels. You all would have heard of pixels. Yes, megapixel you have, okay. So these are all pixels. The more the number of pixels, the better is the resolution. The better is the resolution, clearer is the image. In the context of assessment, each of this, what you call pixel, is a data point. They call it data point. Data point is a unit of observation. You observe over a period of time. Each unit, the student is alert, the student is not alert, the student is punctual, student is not punctual. Each of this, whatever you observe, not one time, but multiple times. The student is alert when this topic is being taught. The student is not interested when that topic is being taught. So all these are data points. So the multiple data points you assemble to get the final picture. When you decide that this is the actual picture, this is the authentic picture. Similarly, you say this is the authentic person, the student, and this is what the student has. You don't decide this is what is the student. A very hazy picture. You don't pass the student at this level. You don't pass the student at this level. You say the student is passed at this level. At this level, you say there is no clarity, we have to improve the clarity, which is a feedback. To say what the student has to improve on. It's a kind of observation and feedback. And this observation and feedback happens both from a close range and a long range. It happens for cognitive, affective, psychomotor, all the three domains together. And it happens in a range of contexts. It can happen when you are teaching. It can happen when you are conducting an assessment. It can happen when you are doing a viva, practical performance. All these are put together, and as a kind of cumulative effort, you make this decision, and that decision is like a longitudinal. You have multiple data points which are running through like this. This is called as programmatic assessment. So when you say programmatic assessment, it's a program of assessment which has multiple tools, multiple contexts, and multiple levels. So all these come together to form a 3D image. When you say 3D image, you get a complete picture that from whichever angle you see it looks, you can identify it. So from whichever angle you see the student, you can identify. That is what is a programmatic assessment. And what does this programmatic assessment consist of? It has multiple tools, multiple approaches, and multiple formats. So the forms of assessment could be formative or summative. Formative is as the student is progressing, you observe and give feedback to improve. Like when the potter is doing this job, he doesn't conclude or she doesn't conclude this is the final image or this is the final product. Goes on working on this for a time. As that person is going on, doing on it, working on it, the shape is emerging. If I don't like the shape, I can make the changes there itself. And finally, when you come to the final product, this is what is the, okay, no, I agree, this is what I wanted to do. You had an idea, this is the outcome. And it conforms to the outcome. That is what is the summative assessment. Formative assessment is towards the kind of formative assessment outcome, you are working on it. One thing that differentiates between formative and summative is decision. If you take a decision on some performance, that is summative. If you don't take a decision, you don't take decision. You give feedback. Feedback is formative. If you are doing this fine, go on working on this, improve more on this, formative. This is not the way you change this, and this can happen this way, formative. Everything is over, pass or fail. You can go to the next level. You are eligible for appearing for university exam, decision. So it is summative. So when we look at this in a practice, we have an understanding that internal assessment is formative. The internal assessment, when we are conducting, we say whatever assessment, PA1, PA2, all these things, you say that the student has to score this minimum percentage to be eligible for university exam. Is it not a decision? You decide this person is eligible or not eligible. It's a decision, it's a judgment. So that doesn't become formative, it is summative. For our convenience, we may say it is formative, but it is summative. When you decide, when you judge, this person is not eligible, this person is eligible, that becomes summative. So this is just a thought for you. So these are the methods of assessment. Then you have the approaches of assessment, which could be direct approach or indirect approach. When the student is in front of you, performance is in front of you, like in the viva, in the practical, in the clinical, that is direct approach. When the student's paper is there and you are making the scoring later, that could be something which is indirect approach. So there are multiple approaches. Then how the assessment has to be? The assessment has to be directly related to the educational objectives. That is what we say, the SLO becomes the question. There's a direct link between the SLO, the outcome, and the question, assessment. The second thing is it has to be about what is useful and important. What is useful and important is designed by what is the priority, what is must know, desirable to know. That decides what is useful and important. And whatever assessment has to be something which is realistic and practical. The student should be able to do that, and the teacher should be able to do that. A little more of this we'll discuss in the last slide of this session. Your attention here. If I have only one hammer, that is my only tool, then whatever problem I see, it all looks like nail. I'll hammer whatever is there because that is the only tool I know. If I know only the theory exam, for everything I'll conduct theory exam. The student is able to communicate with the patient, give a essay question. Right. So therefore, we need to understand that there are specific tools for specific purposes. And that is what is important in our understanding for CBDC. For this, we have the model of Miller's pyramid, which you all know, knows, how, shows how, and does. For each of these levels, there are some specific assessment tools. For only knows how, the student is able to recall, you have this knows how, little more in depth. For shows how, you can see it is not about the knowledge, it is about their performance. And then if it is about does independently, so these are the tools that we have. A little more of this we'll discuss later. This is a general overview. Coming to the specific tools, depending on the domain, depending on the domain, the level of Gilbert, the domain of Bloom, level of Gilbert, and the performance you expect of the student, you have different tools. And more of these tools will be discussed in your afternoon session, and maybe there will be a handbook that can give you details of these later. Some of these we'll discuss in the next slides. For the theory-based assessment, you have two types of questions. One is called supply type, the other is called open-ended. Supply type is when you have some option and you select from those options. It is for multiple choice question, true or false, matching type. Then open-ended is essay, short answer, short open question. And the purpose of supply type is for recall of facts, what you see in the knows, and maximum knows how. And open-ended is for knows how and beyond that into the decision-making capacity. Whatever is C2, C3 will be for open-ended questions. C1 and maximum C2 for the supply type. And please remember, all this is only for cognitive domain. Nothing of this theory-based assessment for either affective or psychomotor. Now MCQ, the structure is it has a stem. It could be the text of the question or a problem statement or some information that helps you to identify what is the option. Then there is a key answer. Key is the answer. These are the specific terms which are used. And then there are distractors which are the incorrect answers. Together these are called item. Together the whole thing is called item. So in a multiple choice question, the question is called item. Okay. Now the example of this is the stem. I can hear somebody murmuring something there. If you are talking on phone, please go out. I don't want any disturbance, neither to me nor to the audience. This is the stem. Then you have the options. So these are the options from which the student has to select which is the right answer. So whatever is the wrong answer, these are options. Whatever is the wrong answer, which is not the right answer, these are called distractors. These distract away from the actual answer. And what is the answer is called as the key. This is the key. And finally, the whole thing is called item. This is the structure of multiple choice question. How to design this? Again, you need to have a workshop on designing multiple choice questions. The reason why we are having this discussion is because the CBDC has a new model of question paper. In that question paper, there are going to be 10 multiple choice questions. So you need to have an understanding of what these MCQs are. You will be knowing, you might be knowing, but there are some protocols of designing this. You have to be aware of it. Then the next thing is, apart from multiple choice questions, there are some more changes which have happened. There is something called as short answer question. There is something called as long answer question. Most of the universities are conversant with long answer questions being for 15 marks, 12 marks, 20 marks. Now, all over the country, the long answer question will be only for 10 marks. And the short answer questions will be for 5 marks. So this is the protocol which is there, and we have to conform to that. So for that reason, we have to understand how these questions have to be. Do we say that, okay, for the short answer question, do we say something like describe something or explain something? Or is it something more specific which has to be done? So the short answer question, the purpose is that you check the students' understanding of key concepts by giving a clinical scenario or a problem solving skill, and their ability to not only recall but also to relate and integrate multiple options or multiple learning. So this is what is the purpose of short answer question. Some of the examples could be something like this. Some of these are good examples, some of these are not good examples. Whatever is not a good example, you can improvise on that. So this could be some of the things which can be for examples for short answer question. Now coming to long answer question, these long answer questions are somewhat similar to the short answer question, but these have a much more depth than the short answer question, where you get to check the students' ability for critical thinking, problem solving, and their analytical ability. All these things which come into the C3, the cognitive 3 level. For that, the long answer questions are appropriate. Now, the examples could be something like this. So again, here you can see some of them are good examples, some of them are not good examples. You try to improvise in your own subjects how to improve the questions. Now, what has happened is we have 10-mark question, and in the 10-mark question, there are 5 10-mark questions. To bring variety into the long answer question, I will be introducing you to 2 different modifications of long answer question. One is called as structured essay question, which is an outline. The structured essay question has an outline so that the students can answer within that. If there is something like describe something, say describe inflammation. Describe inflammation can run into about 40-50 pages. How much does the student write? Within those 15 minutes. So you need to have a structure. You can say define inflammation, classify inflammation, or something like that. So that there is a framework or a structure or an outline within which the student has the clarity to answer. And there are specific sub-questions, multiple questions. The examples could be something like this. You have a situation, and in relation to the situation, certain questions are asked, or something like this. What you can see here is, there is a specific expectation of the student to perform. It is not vague. And even the scoring has some parameters. Say, for example, in the first instance, out of those 4, each of them may carry something like 2 marks or 3 marks or 1 mark or 4 marks. If suppose the student, this is carrying 1 mark, and the student has not answered this, it is -1. You are doing the valuation for scoring for 9 marks, whatever answer is there. Or if the student has not answered these 2, which carry about 6 marks, then you are doing the scoring only for 4 marks. Because there is a specific outline. If this outline is not there, what will happen? The student has not answered this, but has written very well about these two. We have a sympathy factor coming now. So nicely, those two are written. So instead of doing the scoring for 6 marks, we'll be doing for 10 marks. Right? So there we are biased. The scoring is biased. So to avoid that bias, you need to have this structure. This is called structured essay question. Now the second thing is, next one is called a modified essay question. Modified essay question, there is a clinical situation and the student's knowledge of solving that clinical question, it becomes the question. They start asking question. It could be something like this, one example. This is a situation and these questions are related to that particular situation. Now you may ask, what is the difference between the structured essay question and modified essay question? The differentiation is very simple. Structured essay question is only about the theoretical knowledge of the student. What do they know about? How do they relate to that? What is their ability to analyze? Whereas in the modified essay question, it is about a clinical application of that theory. In structured essay question, the application of theory into clinical practice is not there. It is there understanding and relating of the different aspects of theory. Here application into the practice. That is the difference. Otherwise they look same. Then we have the practical assessment. Okay, we have the practical assessment now, or clinical assessment. In that, when the student is performing something, like a student is measuring the blood pressure, very simple thing. How do we say the student's measurement of blood pressure is acceptable competence? To say this acceptable competence, we have some kind of a activities. The student has to do this. You have a list of activities starting from 1 to whatever. So those activities are written as checklist. List of activities. You check whether the student has done or not done. Right, that is called as checklist. Then the rating scale is the another one where you rate the quality of performance. In the checklist, you only have said it is done or not done. In the rating scale, the same activity, you say on the scale of 3, on the scale of 5, how was the quality of that performance? So this is the difference between checklist and rating scale. Checklist is binary, yes or no. Rating scale is qualitative. Checklist is quantitative. Rating scale is qualitative. To give an example, this is a checklist. And this is what we use for whatever I was telling earlier about micro teaching. For the teaching presentation, we use this checklist to say whether the teacher, no, for the postgraduates or for the teachers, we use this. Student has done this or not done this? Yes or no? If the student has done, out of these 15, 5 the student has done, 10 he has not done. Out of 15, 5 marks. Student has done all the 15 marks, has not done even 1, 0 marks. So it is very objective. And the rating scale could look like this. When you are conducting a kind of journal club for the postgraduate students, as they present the journal club, these are the things we'll be checking. And what is this poor, average, below average? Rating scale. Now the question comes, what is this poor, what is this average, what is this very good? How do you define it? It becomes very arbitrary here. So to improve on that, the next level is called as rubric. Rubric is a set of activities, a range of activities, a range of competencies which are checked, and on a scale of performance. And it could look somewhat like this. So these are the criteria and these are the competencies. So this competency, if you say the student has done excellent, this is what is the excellent. So there is a clarity to say this is excellent. There is no opinion. And the other use of this rubric, before we go further, let me clarify 3 terms. One is called as assessment of learning. Assessment of learning is to check what the students have learned. And this is what is called as summative assessment. Assessment of learning. Learning is over. Now you are assessing what the students have learned. This is summative assessment. Second is assessment for learning. Assessment for learning is to help the students to improve. That is formative learning. Exactly. That is formative learning. Now we have a third dimension. It is called assessment as learning. Assessment as learning is where the assessment and learning are together. There's no differentiation between assessment and learning. This rubric, this checklist, this rating scale can also be used as assessment as learning. Because when we are teaching, we tell these are the things we'll be checking for your assessment. These are the outcomes, and these we'll be checking. The outcomes and assessment are into the same tool of checklist, same tool of rating scale, same tool as rubric. So these can be the lesson planner also for you. This can be the assessment also for you. This is where this constructive alignment comes in. Next, we have something called as mini clinical evaluation exercise. So this you would have come across in QCI. A mini clinical evaluation is like a checklist or rating scale or even whatever you call rubric into specific clinical situation. Say for example, if you are checking for the history taking, if you are checking for the physical examination, if you are doing for some clinical examination, there can be specific activities that you check on the student, and these look somewhat like this. A table may look like this, mini CX. These are about clinical performances like history taking. And after the history taking, when you are doing some procedure of say, sometimes even diagnostic procedure is involved into what is called as DOPS. And DOPS also you have come across for QCA. It is direct observation of procedural skills. Please mark the word procedures. So what are the procedures? These could be the procedures. So how does the student perform these procedures? There could be something like this, a table or thing which you can use. And all these, okay, now there is one more called script concordance test. These are some of the new things which are coming up now. Script is the narrative or the story. Concordance is its compliance with something else, like you have concordance repertory. Homogeneity or similarity. So what happens here is, in an uncertain situation, when the story is incomplete, how does the student take a decision, a clinical decision? There's a history, and deliberately you have removed some information from there. And you have given that to the student, you make a decision now. The student says, these are the missing information, and I want these information to complete. And for that, an expert has already written the story that this is a complete story. This is the history, this is the lab findings, these are the physical exam findings, and all these give the outcome of this is the condition, this is the diagnosis. If the student's script matches with the expert's script, that is what you see, script concordance. How much the student is able to take a decision in uncertain situation, incomplete situation. That is called script concordance. This is just about nice to know for you because still emerging. Even if you ask your friends in medical college what is script concordance, they'll say what it is. Then you have something called as key feature item or key feature question. The key feature question is in the clinical decision, there are some critical situations which the students have to do. Must, these are must. And these are listed. It is like your keynote. When you say, okay, I saw the patient, he was coming like this, and this was the gait, and this was the way he was talking, I gave this medicine. Keynote. And it worked. Keynote. That is what is key feature. Key feature is there are certain critical features which are important and essential for a particular decision. These are key features. Second thing is, there are some areas which the students make mistake repeatedly. You can see invariably this is the thing that every student will make a mistake. And those things are listed either from your experience or from the published literature. That list is made, and when you assess the student, you check only that. Instead of doing a 2-hour clinical assessment of the student, you can make a 5-minute assessment of the student to check only these things. These are called key feature items. And all these things get together into something called as a composite assessment called OSCE, Objective Structured Clinical Examination, which has multiple dimensions. Some of these are the dimensions. And this is where you check for the student. And the skills that are tested include, here you can fix mini CX, here you can fix DOPS, here you can have a rating scale, here you can have a kind of checklist, you can have a rubric. All these things can fit into any of these. And the OSCE station looks like this. You have the history taking happening here. You have the some kind of interpretation station happening here. You have some communication happening here. You have some physical examination happening. All these things are happening simultaneously into different stations. And a similar one for practical is called OSPE, Objective Structured Practical Examination. Again here, the practical aspect of it, different stations. And this is what you have to check into the Viva. In the Viva, whatever you see here, the blue is for both formative and summative, and this is mostly for formative. These are the higher cognitive domain. This is what is the affective domain. Right. And the last discussion is preparing the question paper. You all know that in the question paper there are about number of questions. There are some MCQs, there are short answer questions, there are long answer questions. And the student has to complete the whole question paper within 3 hours, 180 minutes. So how do we budget that 180 minutes? You have MCQ which the student can answer in 1 minute. There are 10 MCQs, 10 minutes gone there. Then there are short answer questions which we have estimated the student can answer or must be able to answer within 8 minutes. There are 8 MCQs, so 64 minutes. And there are long answer questions including the MEQ and SEQ, which the student has to answer within 15 minutes, and there are about 5, so 75 minutes. The total writing time is 153 minutes, only writing time, no thinking, just writing. Right, 153 minutes. What are you now left with? 27 minutes. So, when you are preparing the question, long answer question, 10 marks, just check with your students, average intelligence, average writing speed, whether that student can complete that in 15 minutes. If it is short answer question, can they complete in 8 minutes? Only then you say it is pass. Otherwise, rewrite that question. Because if the question requires more time, the student will not answer all the questions. If the student doesn't answer all the questions, they will have the anxiety, and that anxiety will spill over many places. We don't know where it will go. And don't take that chance. And finally, you are left with 27 minutes, which can be used as 5 minutes for orientation, and 10 minutes for revision, and another 12 minutes as buffer time. Your 180 minutes is there. So keeping this 180 minutes as your target, within that, how much you can complete, how much the student can complete. Taking all these, if you can finally prepare a question paper which stands the test of time, your CBDC is successful. The entire success of CBDC depends on the question paper. So take it seriously and work on it. With that, these are the objectives we had for this session. Hopefully some of these are taken care. Thank you.